Hey, thank you very much, and thank you for that introduction. I'm not sure I entirely recognize myself in that, but we'll do our best to fulfill that function. Just say I probably won't disagree hugely with many of the points Vito made, because I think they're borne out by experience and research and from the individual lived experience as well. But I'm going to describe, and I hope you can see my slides from your perspective there, but when we talk about the great outdoors in terms of what's our natural habitat, where would we like to live, where would we have a good life, the life we would wish to lead and to celebrate and to embrace that and be fully enchanted with life. And I suppose for those of us who worked in mental health service in lots of different guises over the years, and we have had some successes, we've also had some challenges. And I'm noting in some instances, probably a sense of nostalgia, and it's perhaps a misplaced nostalgia. So as opposed to the great outdoors, what about the not so great indoors? And I suppose in Ireland, we can speak about this with a certain authority, because in the 1950s, we held the world record for psychiatric hospitalization. So our ratio of psychiatric care to population, just less than 1% of our population lived in what were then 22 large psychiatric hospitals. They were very, very basic. Certainly people made heroic efforts to make them some way responsive, but they were cheap and cheerless, and large numbers of people with a whole variety of needs, including neurological needs, social needs, addiction, elderly care, people with learning disabilities, people with mental illness, people who are socially different found their way into this system. So in the world rankings, Ireland, Russia, and USA had the highest bed ratios. And I suppose with a certain Celtic zeal, we've swung the pendulum from that extraordinary high point to a new scenario. I think not to be too critical of our predecessors, in Victorian times when many of these institutions were built and developed, this was the best technology. This was an enormous investment. This was a huge response to rapid industrialization, to supporting vulnerable people within their communities, some degree of dignity. And I'd like to think that our generation would also be accused of using our best technology, our newest insights, and this level of resource. And I suspect we won't be found to have done so. Let's just track back a little bit. And I suppose in the mental health space, the moon has certainly been implicated in lots of things. But here's a slightly oblique view. So if we want to look at mental health service, we have to understand, as Viggo said, they are part of a wider ecosystem. What's going on in the world? I think Napoleon has a great quote that says, if you want to understand a man, you need to know what was going on in the world when he was 20. And if we look back to care in the community in terms of its inception and where this came from, in September 1962, John F. Kennedy, American president, set a really ambitious plan. He said, we're going to the moon. He said, we chose to go to the moon in this decade and do other things, not because they're easy, but because they're hard. Because the goal will serve to organize and measure the best of our energies and skills, and because the challenge is one that we will accept, one we're unwilling to postpone, and one we intend to win, and others too. This was a really ambitious, and it sounded like science fiction, it sounded out of reality, and it was a really dramatic vision that people could subscribe to. Some 5 months later, he had another ambitious plan. And in February 1963, he said, I'm proposing a new approach to mental illness and mental retardation, using the language of today. This approach is designed in large measure to use federal resources to stimulate state, local, and private action. And then he visualized what this might look like on completion. So when carried out, reliance on the cold mercy of custodial isolation will be supplanted by the open warmth of community concern and capability. Emphasis on prevention, treatment, and rehabilitation will be substituted for desultory interest in confining patients in an institution to wither away. This also sounded far-fetched, and it was very, very ambitious, and it was certainly quite a break from the reality. And I suppose mental health services, one of the things they had attempted to do was to create order and regularity. And they cocooned themselves in such a way that life carried on, irregardless of what was happening in the wider community, whether it was economic success or famine or conflict or war. life continued on its own steady metronome. So he was really proposing a very ambitious program here. Less than a decade before this, we know that people working with new medications and new treatment had happened upon chlorpromazine. And it's interesting in Vito's presentation in terms of describing it as a hiccup. When May and Baker were marketing chlorpromazine in the UK, they called it Largactil because it had a large number of actions. It was antiemetic. It could reduce body temperature. It could stimulate appetite and increase weight gain. It was an antihistamine. It was sedative, and it was also antipsychotic. But interestingly, if you use it intravenously, it can also cure hiccups. So this photo from one of the large hospitals in Dublin, graffiti on the wall, I think refers to the band and not to the activity happening within. But suddenly people began to get symptom control at least and emerge from hospitals. But the question was the community ready for this? And could people be received back into a community who had recoiled from them and rejected them to some extent? When we use the language of community, oftentimes people are describing a geographic space. And I suppose in more modern times, we have a sense of community of interest, community of sameness. So like a Google Maps view of the Trinity College campus in Dublin. And this is a very vibrant community with a blend of students and activities and academic staff. And it's very much part of a wider community. But what do we understand by the definition of community? So is it a group of people living in the same place, with particular characteristics in common? The people who live together and practice a sense of common ownership, a sense of belonging and connection. People with distinct, in a district who are considered collectively, where they share certain social values and responsibilities and have that sense of responsibility to themselves and indeed to their neighbor. And a condition where certain attitudes and interests are held in common and they prevail. And there are certain expectations, the social grammar that goes with a community, but where there's joint ownership and liability. So is that what we mean? And I think as Vito has already described, there's often a sense that the community was a theatre of operation as opposed to a resource, where it's a resource with its own kinks, its own foibles, its own dialect, its own distinct strengths, and indeed limitations. So when we decided to embark and set off for the community, and I suppose I've heard some practitioners describe that in the 1980s, we set off for the community, but by the time we got there, it was gone. But there was a service-centric view and a system-centric view that said, well, what are the tools we need to actually get out there? And I think as, again, Vito was described, having a very clear plan and a structure to devise that plan and develop it and bring it forward and make sure that it's contextual. It's not an import, it's not a pop-up. It's something that, there's a very clear picture, it's attainable, it's achievable, it's timelined. The question is, do we have the infrastructure? So in Ireland, for example, we went from having 22 large hospitals to having over 800 new facilities, some of which were standalone in community residence, and some are integration into other parts of the health system or integration into other parts of a community. That takes significant investment, significant timelines, and a lot of the enabling works actually exist outside of health and social care systems with interdependence on housing providers and employment providers, educational providers, criminal justice systems. All of these interactions, if you cannot take one element out of that jigsaw, reshape it and expect it to fit back in without expecting adaptation from its neighboring elements. The question is, did we have the techniques, the tools, the skill sets, indeed the workforce? And we have to bear in mind that the large hospitals often acted as a reservoir of various professions across all disciplines. And as they decanted into the community, the question was that a different skill set? So there's a role here in terms of being able to interact with the community, understand it as it is, because we know that hospitals and institutions are a contrived artificial setting. But what's that look like out in the real world? One of the great service user leaders, a man called Con Kyo, who worked in Australia for many years, he described that if you only have a hammer, you must treat everything as a nail. So it's about having an array of tools and a whole raft of different skills. So not a holster, but a utility belt of skill sets that you can call upon, much richer multidisciplinary environment and non-health expertise to operate within the community effectively. Again, a point around resources. And we'll come back in a moment and we'll discuss this a little bit more. But when these ideals came in contact with people like Ronald Reagan or Margaret Thatcher, suddenly this was seen as resource raiding. So this very large resource in terms of staff and infrastructure and buildings, etc. Could they be capitalized? And the question is, can you retain that within the mental health service? Because you've broken open its boundary and it begins to spill out and large amounts of resources lost. Or sometimes the resource is at a key moment and then changes over time. We'll explore this a little bit in a moment. What about the technical advice? Where do you get this expertise? If you run into difficulties, if you hit a bump in the road, if you bounce off the wall, as Vita was described there. And this should not be imported. There's an expression in the Irish language that says, no matter how tall your father was, you must do your own growing. So having a flyby genius from elsewhere, they also need to pack their suitcase. And if they can get through an airport in the current context, they fly home again. If you're going to have ownership, you need to have people who are going to have to live with, succeed, or suffer with the model and be able to adapt it and contextualize it and make it real. Context gives meaning to everything. These concepts are very abstract and are not particularly useful unless you apply them in real communities around real people's lives, with their families engaged, with the individual very actively involved in co-production and co-creation. One of my favorite instructions in IKEA is saying, don't do this on your own. Care in the community is not a solo pursuit. It cannot be inserted, it cannot be paratrooped into community. You must have community partners. You need to recognize that the partners have needs. If the partner doesn't have needs or those needs aren't being met, chances are you don't have a sustainable solution. So you need to go out and trade. You need to have a relationship and have staff who have that outlook and are curious and creative and can be really imaginative. And I say imaginative, not imaginary. You must follow through and your credibility will be very real here. I think as Vita was also mentioned, we're conscious that this network is dedicated to all area of evaluation and research, is making sure that we have valid indicators and measures. How do we know we're on course? Are we executing effectively? Is this plan still a valid plan? Has the context changed radically? And are we ready? And I suppose there has been a temptation for lots of service planners and senior leads and people driving policy at governmental level, minister level, ministry, departments, etc. And oftentimes the question is posed to themselves. It's a very inward-looking piece saying, are we ready? Without necessarily saying, are the community ready to receive us? Are the community willing? And are they active partners in this relationship? So when we ask, are we ready? There had been a tendency, I suppose, in the early stages of deinstitutionalization in particular, wasn't to move to the community, it was actually to move the hospital out and basically create an inefficient hospital model. And we took hospital value systems like X-ray, for example, and we tried to recreate these at a domestic scale. And we brought sometimes a more intrusive form of institutionalization into the community and created a parallel universe where people lived but wasn't really part of their community and wasn't fully integrated with their neighbors. There was also a very large risk of disassembly. In the west of Ireland is a smallish town called Ballinasloe. Ballinasloe hosted the largest hospital in its region. In fact, half of the population of this town were either service users or staff members working in what was then St. Bridget's Hospital. And the hospital began to disassemble itself, taking units and staff and resources and service users and all of the infrastructure and saturated the community to create something of a ghetto and a cluster. And according to national policy in that county, there should be 9 community residences. At a point in time, there were 59. So essentially, the roles, the jobs, the investment of the state, the resources were spilling into that community, which was very reluctant to release that. But it also gave a very unusual and heavy pathological demographic to the neighborhood in terms of significant amount of mental health need was clustered in that area. And it opened a dynamic which wasn't really helpful and wasn't necessarily conducive to providing good community care. In mental health services across Europe and indeed across the world, there was a tendency to reassemble what we already had. I sometimes describe this as the Apollo 13 approach. So Apollo 13, when they ran into difficulties, they could only fashion a solution from objects and material that were on board. There was no point in saying we need a particular tool or we need a particular material. Unless it was on board, it wasn't available to you. And there was a tendency in mental health services to recreate themselves from what was within. I remember visiting a community high support hostel on a very wet day. And when I got to the door, where there should have been a doormat was a bedsheet. And as I stepped in, I traveled a distance and said, can I use your bathroom? And in the bathroom, where there should have been a towel, was a bedsheet. And I was offered a cup of tea by the residents, and really very nice welcome, very authentic, very real. And then I noticed that the tablecloth was also a bedsheet. All of this resource had been raided from the old hospital, which had been staffed and equipped to do certain things, but they weren't designed for living in the community. So people had to refashion and reuse pieces. And I think across all of our careers, no matter what enterprise we work in, there can be a temptation to gravitate towards, a bad idea well executed as opposed to a good idea badly executed. Ideally, if we can have a good idea well executed, that's the sweet spot. And that can be very elusive. Just to give you a sense, when I began my career in 1983, in Ireland at that point, we had 12,000 beds. There was sufficient beds for every man, woman, and child in the country to spend an overnight in a psychiatric hospital. As it happened, there was a particularly loyal clientele who were occupying many of these beds, so lots of people didn't get their turn. But through a policy document called Planning for the Future, which was published in November 1984, it saw a radically different model: care within the community, inpatient units in acute hospitals, and the closure and relocation of individuals from old hospitals into community living at high, low, or medium support, depending on their particular level of need. And we saw a very sudden change in terms of bed numbers. This policy document was replaced in 2006 by another document called A Vision for Change. And again, this huge swing, a pendular swing in bed numbers. So Ireland going from having the world's highest bed base, now compared to the OECD partners, we have about 21 beds per 100,000. European norm is between 54 and 72 beds. I think some of our colleagues from Slovakia who visited last year have almost 300 beds per 100,000 population. This can really only be contemplated with a massive, sustained, and effective investment in community-based services, in community-based teams for adults, children, older persons, in support and recovery and rehabilitation teams, and a whole range of other elements within that. And that does require sustained investment, sustained political interest, and rolling over in the political domain or in the leadership domain does not lend itself to that long-haul ambition. In June of last year, the Department of Health published Sharing the Vision, which is our current mental health policy for the next number of years. I think, as Visha was mentioned, there are some unintended effects. And sometimes in the institution where people felt they were going round and round in circles and the institution had become the problem, if we could simply dispose of that, everything would be fine. I think the experience internationally has been a little bit different. We've certainly seen, as mental health beds reduce, prison populations have grown. It's recognized as the Penrose Law after Emil Penrose, who was a psychiatrist and a statistician working in the UK. And we've seen these numbers replicated in many, many jurisdictions. So this is not progress. In the public's mind, there can be a visibility saying, well, I don't see the problem. But certainly in many states, particularly in the US, as in Washington 2 weeks ago, you will regularly encounter people with frank and acute mental illness on the streets, unsupported. So it's a libertarian model and the state abandonment. And we shouldn't confuse these two phenomena. In terms of resource, if we can imagine health spending as a cake, if we look at the percentage of mental health spending that's dedicated from the health spending budget, in 1963 in Ireland, this represented 23% of the entire health spend, which was enormous. A significant portion of that was in maintaining and heating and building and painting large buildings. It didn't necessarily equate to high service standards. By 1984, this number had reduced to 12%. 12% is what WHO recommends. In fact, in some conversations I've had with colleagues in WHO, they would say, if you can't spend 12%, don't even attempt or pretend to provide a mental health service. That's your entry level. In our instance, in 2009, our mental health spending as a proportion of health budget had dropped below 7% to 6.7%. And in 2020, this new policy set the target at 10%, still below the WHO levels, but set that target. Today, in 2022, Irish mental health services are operating on 6.5% of health spending. So this will obviously mean services are delayed, are limited, are often a thin veneer, when they really need to be much more rich in terms of the opportunities they can offer, the choice they can offer, and engage with service users on terms they would wish to. We also need to be very mindful of costly transitions. You simply can't switch off one option and turn on another. There is a period of transition which requires additional investment, so you can liberate yourself from older models. And as these older models get into their final stage, they become extraordinarily expensive and economically inefficient. The last people to leave these large services often have very complex needs, and forward provision is quite a challenge. But if you did a census and you track people across time, and we find that the people who left the institutions oftentimes were very well provided for. But one of the interesting things, if we ask where are they now, they're still orbiting the mental health service. They still have had an overly exertive gravitational effect on their lives. But also that generation, as Ficho has described, neither the final generation nor the penultimate generation, they took the resource which would be available to future generations. In our ambition and in our hopes and expectations that we'd finally move beyond severe and enduring mental illness, the expectation was that we wouldn't need that resource any further, and that endowment followed a particular group of people at a particular moment in time. The question is, what's available for the next generation coming forward? And for people with continuing care needs, and there's certainly some innovative models around social farming and other programs, but these are really only available to relatively small groups of people. So we need to be very mindful that you can only sell the family jewels once, and then the question is, then what? What's your next plan? Where do you go after that? I think if you're ever building a bridge, it's always useful to have someone on the opposite bank building towards you. And as we move to the community, we need to have native guides who are of the community, live in that community, are invested in that community, are natural leaders. And sometimes they're titular leaders in terms of public representatives, but sometimes they're actually touchstone leaders who actually live within the community, understand it, and are fully committed to it. And it's about building these bridges successfully and understanding the needs of both parties. And even at a neurological level, I think we understand it's that synaptic space which is so important. That's where the action is. So no matter what infrastructure you create either side of that, where they meet, how that dialogue plays out, is it respectful? Is there a parity of relationship? And how is it monitored and how is it mitigated across time? That is the real skill set in developing and sustaining community-based care. If we're to work with communities, we need to understand where they're coming from. And many communities are naturally more liberal and tolerant and accepting. Others are much more conservative and quite cautious and protective to the point of being hostile at times. But the question is, has the community been fully engaged with? Is it informed? Is it involved? Is it actually supportive? Have they been consulted? Are they actively collaborating? Are they partners in this relationship? And is there a natural inclination to celebrate or tolerate difference, or to be cautious of it and to be protective? We need to challenge NIMBYism, as in not in my backyard. So people like these ideas as a kind of an aspiration, but you could try it somewhere else first. We need to have active dialogues and even a trialogue where people with lived experience, family members and professionals with their local community collaborate to see what are the advantages here, what are the concerns. And we need to promote a concept of community understanding. And this is in two senses, an informational piece around mental health literacy, but also an empathetic understanding that over the course of my lifetime, myself or my family members, or my near neighbors we indeed ourselves will have significant mental health challenges, and how do we want that received into the future? We also have to be very honest in terms of, as health service providers, what are the expectations of the mental health service, as shown in the graphic here? Is it that you'll simply step in and remove people if their behavior becomes different or problematic, or they're at risk or posing a challenge? And the level of trust in the mental health service. Can it be responsive? Will it actually intervene helpfully, creatively, in a nimble and agile way that supports the individual with dignity and respects their community's needs? And I suppose a very fundamental question when we use this language of community care, but have we actually asked, and do we have a mandate that says, does the community care? And how do we know this? And do they care more now than previously? Or has the community become transient of a whole series of people who just share a geographic space, but actually aren't fully invested in the longer term? A really interesting model we've seen emerging from Philadelphia. And Philadelphia is a beautiful city if you're in the center of it, but if you move out about 2 kilometers in any direction, you'll find an post-industrial wasteland. And Arthur Evans, who was the commissioner of mental health service, realized that he couldn't provide, no matter how well resourced he was, a dramatic interventionist mental health service in an environment which was essentially toxic. And he devised the concept of Thrive, where you engage with communities, celebrate their strengths, know what their needs are, and respond to those needs. This model was moved to New York City, where they have an $85 million budget to engage with communities and mobilize a whole series of community-based partners. In the UK, there's Sadiq Khan, the mayor of London, has invested in the London Thrive with a €12 million budget to engage with Londoners. And they began in a very clever way. They asked Londoners, are you okay? In huge surveys. And then they folded it back and said, are you okay with 14 people dying by suicide in London every week? And what was a query became a challenge, and people responded to that. We're replicating this model just north of Dublin in a small community called Balbriggan, taking on board some of the ideas from overseas, and it's certainly been an enormous community response to this. Some points to finish. Sometimes there's a view that we can apply new technologies, and we know that old process plus new technologies equals expensive old process. But as people move to community, we need to be very real about recovery and what recovery means. And does recovery mean being symptom-free or being an active contributing member of your community? For far too many people involved being parked in a parallel universe, which wasn't terribly demanding, almost had the edges rounded off. And we really need people to rejoin the traffic. You cannot live out your existence in or around the mental health service unless you have very, very particular needs. And that should be a very tiny group. But we need to have models and pathways forward for people to engage with their wider community. So we definitely need new solutions. We need to have a very strong public mandate and a sustained engagement with communities, not just projectism, as Vito described, this sudden rush of ideas which become spent very quickly, people become burnt out, they move forward, and we have abandoned grand visions, which aren't really helpful and can actually discredit the whole movement of care within the community. I think we've learned a lot over the last 2 years in terms of our experience of COVID, and where you have really strong sense of community, sense of belonging, sense of community cohesion. This has been a really powerful effect. We've also seen the corrosive effect of breaking open those chains of community, where people felt isolated, sometimes necessary public health measures for cocooning, for people who are vulnerable or immunosuppressed in some way. But I think more and more people are beginning to appreciate that we must live within our community, we have to contribute to that community, and that's where we achieve full mental health. So to go back to the basic script, I suppose, and I don't think JFK got everything right, but he said, you know, when we get to a success point, when carried out, reliance on the cold mercy of custodial isolation will be supplanted by open, warm community concern and capability. So capacity building and capability and investing within communities, with an emphasis across a system of care, which includes prevention, treatment, and rehabilitation. We probably now use the language of recovery there instead. So I think we should be ambitious for the future. We still have a lot of work to do, But I think networks like this are an opportunity and a platform to share. And organizations like the International Initiative for Mental Health Leadership brings together leaders from Ireland, England, Scotland, US, Canada, Australia, New Zealand, Sweden, and the Netherlands. And in October this year, we'll be hosting their event for a European hub. It's not possible to go to New Zealand with COVID restrictions. But I think there's a real opportunity, and anyone who'd like to join from any of those member countries, it's free to join. Just go to iimhl.com. You can register there, and we look forward to meeting you in Dublin in October time, if that's possible. So that's my presentation. I think we're going to have a joint session of some questions and answers now. Thank you.
Thank you for the interesting presentation. Now I will go to the chat room and see if we have there any questions.
I have lots of comments, but I haven't actually seen any questions come through so far.
Well, there was a question of Moitza, and I think she got many answers from Martin. I would say very much in the same direction. But I would add also this, that optimism, it's a sad fact, but that we have to the optimism lies in the pessimism, I would say. Yeah? It's because it's like with the climate changes. Yes? If we don't do something now, that it's going to be worse, much worse. Yes, and I think this is it is not so much about the climate, but about the humanity of the society. I think this is the indignation of what is happening. Yes, is one of the driving forces. Yes, and of course, what Martin was saying. Yes, we need to connect to the communities, reinvent the communities. Yes, create the common field. Yes, where in Levinian terms, but also in terms of this bucolic metaphor, yeah, where we can really have a common ground, where we can plant the ideas, where we can work together, yeah, on the issues that are not concerned only as they are ascribed to people who are labeled ill or old or whatever. Yeah? Yeah? This is, I think, and it is utopia, but as Martin was pointing out, that this is not it is in Baselian terms a practical utopia. Yes, it is something that we can do, that we occasionally also do, and so on.
I think we can learn from a number of cultures. If we look at, for example, in Japan, where there's been a significant aging, very rapid industrialization, huge change. So in Japan last year, 29,000 people turned 100. And families are smaller, sometimes there's a sense of disconnection. And a phenomenon known as hikikomori, where young men, but not exclusively young men, and about 1 million young people, and they're now beginning to age into their 40s and perhaps into their 50s, have simply gone off grid. They've opted out, they live in their room, and they don't appear to have autism, they don't appear to have agoraphobia or schizophrenia, but there are young people who felt that they've either disappointed themselves or disappointed their family in some way, in a sense of shame, but they've retreated back from their community. And they have no connectivity bar through the internet. Some will only interact with computers, others will interact with other people via their computer. And this is a really sad reflection, and it's become quite a crisis there, because oftentimes they're depending on elderly parents to care for them and create a life support system for them. And they're articulate, intelligent people. They've been interviewed in lots of documentaries and research, but it's not entirely clear where their future lies because they've become disconnected from the community. And we're seeing this with lots of young people today as well, where their community is always viewed through a screen of some description. I've actually seen this in terms of when my youngest son graduated, he had some friends and cousins over one evening. And midway through the evening, they said, let's order a takeout. Two of these young men would not order food that involved having a phone conversation. They could only order food if it involved tapping on the screen. And when the food was delivered, they were really reluctant to open the door, and they felt that could be a bit awkward. They felt socially ill-equipped. So this is a really important warning sign for us that our wider community and people who lack those skills and don't have that connectivity or don't have a physical space, a platform to actually meet, whether this is in a nature-based setting or a community-based setting or a sport or some common interest, we need to create places that we call community. And I suppose we've had a celebration of individualism, and that's really important and really helpful, but it can't be exclusively so. So it's that interdependency. And I think we've probably learned a lot from COVID. It's a very expensive lesson in so many ways in terms of tragedy and loss and bereavement. But I think it has caused us to reset our compass and recalibrate and say, what's really important here and how do we do that? And good mental health care and good community-based care can only really be a microcosm of the wider value system that pertain within a community. That's where we get our validation. That's where we get an investment of interest and resource. And it is really important that we're visible and clear and can demonstrate the impact of success. Because we know that in mental health, when people do well and have good outcomes, our successes are invisible. People will go back and live in the world and probably not mention that period 2 years ago when their life was in difficulty. When things don't go so well, where there's late interventions or inadequate intervention or unacceptable interventions, that can be very high vis and unfortunately often tragically so. So we need to have a new dialogue and a new relationship with our public representatives and our wider public. What would you wish for? How would you know when you get there? How are you going to contribute to that? And how can we show you that that's actually been successful? So without that dialogue, we could find ourselves seriously off course and finding it very difficult to find resources to maintain essential service models.